everyone, and thank you for joining us today for another Heart for PCOS interview. Today, I have a very special guest that I'm excited to share with you, Dr. Mark Trolice. Welcome, Dr. Trolice.
Thanks, Ashley. I appreciate the invitation, and hello to all the viewers.
Thank you for joining us. Dr. Trolice is the director of the IVF Center and a professor at the University of Central Florida College of Medicine. He's responsible for the medical education of OBGYN residents and medical students, and he is a past president of the Florida Society of Reproductive Endocrinology and Infertility and Central Florida OBGYN Society. Among Dr. Trolice's awards are Social Responsibility and Leadership Awards by the National Polycystic Ovary Syndrome Association, the American College of OBGYN National Faculty Award for Excellence in Residence Education and Mentor of the Year Award, as well as the Osler Teaching Award. Dr. Trolice lectures at national and international seminars and advocates on Capitol Hill, which I'm thrilled about because I've advocated with him. He's awesome. For infertility insurance company coverage, research funding, and awareness. He appears regularly on TV, news, talk shows, radio, podcasts, print, online magazines, and newspapers as an expert on reproductive health topics. He has moderated many global podcasts and webinar in addition to his own called Fertility Health. His recent book is The Fertility Doctor's Guide to Overcoming Infertility, Discovering Your Reproductive Potential and Maximizing Your Odds of Having a Baby. And we are so excited to have you here today because over the years, Dr. Trolice, you have made a major contribution to the PCOS community and PCOS challenge by helping expand awareness, research, and education about PCOS. So again, welcome to you.
It's my pleasure, Ashley. I'm always here for you and the PCOS community. It's near and dear to my heart, so it's a complete pleasure, and I feel so obligated to be involved in any and everything with PCOS.
I'm so happy to hear that because we need more people like you out there educating. So today we are here as part of the 10th anniversary of the Heart for PCOS campaign, which connects PCOS and cardiovascular disease. And often when patients are diagnosed with infertility with PCOS, they are not thinking about cardiovascular disease or maternal fetal health, but research is starting to indicate that maybe we should. So let's start from the beginning. How does PCOS affect pregnancy? And we know for many it affects conception, but we often don't talk about what happens after we conceive with PCOS.
Well, you start off with what is PCOS, right? It's the most common hormone problem in the reproductive years. Estimates are anywhere from 8 to 13%, but I've seen in some studies actually up to 20%. So if you think about it, think of your hand, 1 in 5. And all women probably know somebody, whether it is definitively diagnosed or at least suspected with PCOS. So I look at it when I share with my patients is that it's really a two-pronged process. You mentioned the metabolic with cardiovascular and the reproductive. So we don't know how this started. Theories are when the woman is inside her mom as an embryo, there's exposure to either high levels of male hormone called androgens, like testosterone, androstenedione, things like that, or AMH, which is anti-Müllerian hormone. So one of those triggers the process. You can get a feeling about whether somebody has it during adolescence. You know, they typically will have a little bit earlier in terms of the hair, in secondary sexual characteristic areas, or even legs and arms, things like that. Acne, not as clear of a diagnostic criteria. And then, of course, you don't want to do ultrasounds in the young women because they all have polycystic ovaries, whether they have the disease or not, or the syndrome. So how do we make the diagnosis? Well, it's rather easy, yet women with PCOS know all too well how frustrating it is to get a provider to make the diagnosis. First, the provider needs to take ownership and get invested with their patient who's complaining of these problems, right? So we make the diagnosis by having 2 out of 3 criteria. But interestingly, the number 2 is 2 to 3 years before a woman is diagnosed with that condition. And the majority of women have to see 2 to 3 providers That's just crazy, and it's not necessary, particularly with the amount of education available with online. Providers should be all too knowledgeable about this kind of problem. So how do we make the diagnosis? 2 out of 3 criteria. Some measure of elevated male hormone, okay, either by having the dark hairs in the upper lip, chin, sideburns, neck, chest, lower belly, lower back, upper inner thigh. Those are male pattern areas. They'll even lose some hair as well because of the elevated male hormone. Either they have the hair growth in that area, which has to be pretty substantial. There's a score that women use, that we use for women, called the Ferriman-Galway score. And if it's more than 8, we say that's significant. Or an elevated total testosterone. Free testosterone levels in the blood, not as accurate. I need special testing for that. So you got one criteria, right? Second criteria is lots of small little cysts or an enlarged ovary on ultrasound. So the volume of the ovary has to be big, and you got to have a lot of these small little cysts all over the ovary. Now, I will tell you that as soon as I mention the CYST word, cyst, patients, I lose them because they think every cyst is bad, every cyst is cancer. And I try to say, look, I'm going to take a look at the numbers of small little baby cysts that you have to have because they represent eggs. It's not a problem to have these little guys. The problem is if it's associated with this other criteria with PCOS, it's a reflection of that syndrome. So women can have a lot. First of all, they have to have these little cysts because they represent eggs. So if you're going to try to conceive, you got to have them, and you don't have them anymore in menopause. So these are good to have. The more you have, the more likely you're prone to PCOS. So measurement of the ovary, counting numbers of little baby cysts, second criteria. And what's the third? The third is the most common. The third is ovulation dysfunction. Whether their periods are every 2 to 3 months, 3 to 6 months, never, or they bleed every day. PCOS patients have every combination of ovulation dysfunction with abnormal bleeding because they're not getting the signals from the brain to the ovary that needs consistent, synchronized ovulation function, okay? So the normal menstrual cycles of 28 to 30 days, it can go technically 21 to 35 days, but it needs to be regular. Yeah. So if you're 22 days, then 34 days, then 24 days. So even if it's in the normal range, if it's still very irregular, that's not good. Something to know is that you can have regular cycles, particularly in the PCOS patients, and not be ovulating. Now I'm going to ask you a little quiz question, Ashley.
Okay, I'm ready.
What is the only definitive way that you know somebody's ovulating?
Through blood test.
No. Pregnancy.
Wow, okay.
Pregnancy.
Okay.
Because blood testing for progesterone, urine ovulation prediction for LH, endometrial biopsy, ultrasound, cervical mucus, lower abdominal cramping called Mittelschmerz. All of these things are presumptive. The only way you know for sure is if somebody conceived, right? Okay, so in a PCOS patient, it's estimated up to 20% if they have monthly cycles may not be ovulating, all right? So let's never assume. So the issue is one of reproductive problems and one of metabolic problems. So we can go into these issues as you like, but that's sort of the background.
Okay, so let's clear something up real fast because we're talking about all the cysts and the metabolic issues, but it's not impossible to get pregnant with PCOS, correct?
Oh my gosh, of course not. No, it's not impossible and it warrants a full evaluation. The good news is that patients with PCOS have really the same overall outcome of pregnancy as non-PCOS women. It may take longer, but they do have similar ongoing pregnancy rates cumulatively, okay? So we don't assume. When a patient comes to see us and they're not ovulating regularly, we don't say, okay, that's it. It's ovulation, we're gonna take care of that. You still, about 5 to 10% can have a male factor or a tubal factor. So I think it's appropriate to make sure Sperm is okay and tubes are open before you start investing a lot of effort into trying to get somebody to ovulate. But my gosh, if we couldn't help anybody with PCOS get pregnant, we'd be a laundromat because that's the majority of patients that we see.
Right, right. So why is it important when patients decide that they want to conceive that they optimize their health? How can they help themselves and help this process?
That's the most important question, is how to optimize your health prior to pregnancy. But that's not for just PCOS patients, that's for everybody. If somebody has uncontrolled diabetes, uncontrolled high blood pressure, uncontrolled thyroid, significant overweight, other metabolic problems or other major medical health problems, those should be addressed to give you the healthiest pregnancy and, of course, baby. All right. So what are the things that we have to be concerned about with a PCOS patient? Well, the metabolic syndrome is 2 to 4 times higher in the PCOS population than those that do not have PCOS. What's the metabolic syndrome? 3 out of 5 diseases that hang around together because of these disturbances. Okay. So elevated blood pressure, elevated fasting glucose, elevated triglycerides, low HDL cholesterol, which is the good cholesterol, and then increasing abdominal circumference, waist circumference, okay? You need 3 out of 5 of those guys. PCOS patients have a lot of those, okay? That's one area that you address. We hit that at the first visit. It's not, hi, how are you? Let's make a baby. It's what can we do to give you the best chance for a healthy pregnancy and healthy baby, okay? So what else do PCOS patients have? Well, obviously the hair growth, right? They have higher rates of sleep apnea. They have higher rates of uterine cancer because remember we talked about ovulation dysfunction. If the brain signals to the ovary are not synchronized, you're not ovulating typically. Ovulation, the hormone of ovulation is progesterone. If you're not making progesterone, your body is continuing making estrogen in low amounts, but steady. And the lining of the uterus loves estrogen. And the more it sees estrogen, if it doesn't get countered by progesterone, the lining of the uterus keeps building up. So think about putting a hose in the pool and forgetting to turn the hose off.
Yeah.
That's the overflow bleeding of PCOS, and that's concerning. So studies have shown there are 2 main concerns with patients with PCOS of where they have risks for buildup, precancerous change, and even a cancerous change. One is if your periods go more than 3 months. Never think if you don't get your period, you're lucky. Okay? If you don't get your period, that's a sign. The menstrual cycle is a sign of your reproductive health. Okay? We're not being chauvinistic or misogynistic, okay? We don't want you to suffer with a period, but if you're not having periods, that's an alarm, okay? The second is if your lining of the uterus is more than 7 millimeters. If it's more than 7 millimeters and you're not ovulating, you're at risk. So we have a very low threshold of doing an endometrial biopsy, taking cells off of the uterus to see if you have a precancerous change or even, God forbid, cancer. And we've seen both, okay? Yeah. Depression and anxiety is another association with PCOS, okay? So it is not, it's devastating. It's a devastating problem. We also have to talk about overweight and obesity, okay? It is a subject that is extremely sensitive to women. It is not a judgment by the physician to mention that. It is meant to prescribe better health. So when I talk to patients about weight loss, it's not a punishment, it's a prescription. Because for PCOS patients, that is the one thing that can possibly be done on your end of the consultation room that you can do at home that may improve your fertility. A 5 to 10% reduction in weight loss seems to improve ovulation function. Even if it doesn't, you might be more sensitive to the medication to get you to ovulate. Now, interestingly, it's really equivalent to the rest of society about the weight issue. PCOS patients are not more overweight than the rest of the population. It really matches the population, especially now. People are unfortunately putting on more weight now than ever before. So it really is not, oh, she's overweight, she must have PCOS. No, that's not the answer, okay? But if you are overweight with PCOS, higher rates of that metabolic syndrome and weight loss can help your fertility and, of course, your overall health. So we check blood pressure. I do a 2-hour blood sugar test. We have you drink the sweet stuff and check your blood sugars. Why? Because if you just check a fasting, you could miss an abnormal 2-hour blood sugar 35% of the time. So 1 out of 3 women are walking around with pre-diabetes because the doctor said, oh, your fasting blood sugar is okay. No, don't worry about anything. Not the case, all right? So the first thing we do with a PCOS patient is we look at the metabolic problems, and including the uterus, okay? When we get everything optimized, let's get going full steam ahead if your goal is baby. Your goal may not be for baby. Your goal is to say, look, I can't take this PCOS, all these different issues, the hair, the pre-diabetes, overweight, the blood pressure issues, and then we address that, okay? It's really based on what is most important to you. If you don't want to get pregnant, really the birth control pill is a great thing unless you have any contraindication. The birth control pill is a great thing. Why? Because the estrogen improves the issues of the hair, okay? It increases what's called sex hormone binding globulin and gobbles up any free circulating male hormone. The progesterone will lower LH, okay? And LH as well, LH with insulin, unfortunately, increases male hormone as well. But progesterone protects the lining of the uterus from that precancerous buildup.
Absolutely. So you were talking a little bit about insulin and the role that it plays. So I want to dive into this a little bit further because with pregnancy, there are a lot of things that can come out of your androgens being high or your insulin being high, such as gestational diabetes or things like preeclampsia or high blood pressure. So can we talk a little bit more about this? Like, what is gestational diabetes? What is preeclampsia? Why should we be worried about it when we have PCOS?
Well, gestational diabetes is exactly what it says. Gestational is in pregnancy. And if you have pre-diabetes untreated prior to pregnancy, you're going to have a high risk of diabetes in pregnancy, which is a more strict criteria because elevated blood sugars in pregnancy cause more complications with baby. Severe impaired glucose control can cause birth defects. So we really want to be careful about the complications of diabetes in pregnancy. Gestational diabetes is treated with either diet or even insulin, but metformin is being used now more because of its safety in pregnancy, okay? Blood pressure issues, yes. Once again, any abnormalities before pregnancy don't get better during pregnancy. You need to be controlled before pregnancy, then going into pregnancy. If you have high blood pressure issues, we take a look at the medication that you're on before pregnancy. We don't want you to be on just anything. There are medications that are safer, like labetalol and methyldopa and nifedipine. Those are safer in pregnancy, okay? Preeclampsia is a severe problem of blood pressure control during pregnancy that can cause a cascade of complications affecting liver, resulting in essentially seizures called eclampsia. And severe preeclampsia can result in the need for early delivery, very early delivery, because of the risks to mom and baby.
There's been a lot of controversy actually around using certain medicines in patients that become pregnant with PCOS to avoid complications like gestational diabetes, like metformin. So is using a medication like metformin at the first trimester or throughout pregnancy safe? Or I would love your feedback on that.
Well, metformin during pregnancy should be used for glucose control, okay? If your glucose is controlled, there's no reason for metformin. When we have patients with prediabetes on metformin, we usually continue it throughout the first trimester, okay? But then we'll stop it as long as they don't have, and the obstetrician makes the decision whether they want to continue it based on blood sugar control, okay? So metformin alone has not been shown to improve the live birth rate. That's been studied, okay? Letrozole to get somebody to ovulate seems to be now the gold standard. An article in the New England Journal of Medicine by Dr. LeGros showed that it was better than clomiphene citrate over a 5-month cumulative pregnancy rate. It was lower the higher the body mass index, which is a measure of someone's weight based on their weight and height, okay? And also, it didn't seem like it was much different than clomiphene citrate if your body mass index was less than 30. But we basically will give letrozole for all patients trying to conceive who are PCOS.
We know that healthier moms often create a healthier pregnancy and a healthier baby. However, there are some higher risk of complications, which we were just talking about, associated with PCOS and pregnancy. One thing that I was really concerned about was there was recent research that points to an increased risk of adverse cardiovascular events and pregnancy outcomes at the time of birth, according to a study led by Johns Hopkins Medicine. How concerned do we have to be about this? And are there things that we can do to prevent this?
Yeah, the issue of cardiovascular disease, and when you briefly about the insulin resistance, inositol is a natural sugar, and that's been used to help with insulin resistance. Now, measuring insulin is not the gold standard for prediabetes. A 2-hour blood sugar is. A lot of people will get a fasting insulin, a fasting glucose, but I will always get a 2-hour blood sugar because the American College of Endocrinology is the one that recommends the 2-hour blood sugar as the gold standard, okay? But inositol, and you may see different products that are offering that, have been used to help with insulin resistance. It's a natural sugar, as I said. So when you talk about the issues in pregnancy, cardiovascular, before pregnancy, cardiovascular has been looked at, and it's never been definitively associated with PCOS and risk of cardiovascular disease. Now, there were ultrasounds of the carotid artery that looked at the lining and thickness of the what's called the intima, the endovascular. And yes, it was increased, but the definitive, hey, you have PCOS and this is your risk of a cardiovascular event, it's not there. So interesting, the study from Johns Hopkins, but I don't think we have enough information to know if that is definitive. And secondly, we go back to what we said earlier, right? Healthier you, healthier pregnancy, healthier outcomes. And, I am empathetic when you have an elevated body mass index, and by the time you come to see somebody like me, you don't want to hear that, we really should address the weight.
Yeah.
But that should have been done for the first doctor that you saw. Or it really, you really have to look at ensuring your health even before doctor, right? But that is an issue. It is difficult for PCOS patients to lose weight more than non-PCOS patients. That's been shown, but difficult doesn't mean can't.
Right,
okay?
Exactly.
So it's a question of commitment. I mean, I will tell you that I'm doing this 25 years, okay? I have seen dramatic results from some women and no results from other women. It's perseverance. Not, easier said than done, but it's something that you really have to embrace and not taking no or being discouraged for an answer. It's a question of saying, this is my new lifestyle. I am committed to health for me, future baby, and you can get there.
Yeah, I agree. And one other thing that I'll add to that is I think people also have to realize that it's individualized. I think sometimes we get caught up in, hey, that's working for someone else, that's going to work for me. And that's not always the case because the symptoms are varied, the severity is varied, and our genetic profile is varied. So I think we have to keep that in mind as well, that we have to, as you said, own it and make it our own thing and our own individual.
Well, I don't think it needs to be complicated, though. And there's a tremendous number of books and online information about the PCOS diet per se. It really isn't. You need carbs, fats, and proteins to live. But you need healthy amounts of carbs, fats, and proteins, and healthy fats and carbs, okay? So if you go on a diet that restricts carbs, you can't be on that forever. So why not start off with something you can be on forever? And the best diet that's being voted year after year after year is the Mediterranean diet. It's plant-based. You could be on that forever. I'm on it forever. I absolutely love it, maybe because I'm Italian, but it's just absolutely amazing. It is healthy. Nuts, legumes, berries, fruits, vegetables, olive oil, good fish, not crabs, lobster fish, but salmon and tilapia. And so you really want to take a look at calorie control, Mediterranean diet, but exercise. You know, you can't be thin, not exercise, and be healthy.
Yep.
You can't be overweight and exercising and be healthy.
Yeah.
You need to have a normal BMI and you need to exercise. Okay. So 5 days of cardio and 2 days of strength training. Why? And that's the American Heart Association. Why is strength training more important in PCOS patients than non? Because strength training improves insulin sensitivity. Okay.
That's right. Building the muscles, right?
That's right. So you're going to improve glucose uptake and reduce insulin levels with strength training. And with cardiovascular, what's the name? Cardiovascular, right? That's going to improve your health and expedite weight loss.
Absolutely. So we talked about a lot of really intense things today. So I want you to give us some good news, because you're always like that feel-good doctor to me. So what is the good news in all of this?
I think we did. I think we talked about good news. The good news is that PCOS patients have the same overall pregnancy rate than non-PCOS patients. The good news is that if you are overweight with PCOS, you can help your fertility and your overall health with weight loss. If you're thin and you're not ovulating, you really have less options. But if you are overweight and not ovulating, you can be involved in the improvement of your care. We talked about a positive that the better you are going into pregnancy, the better the pregnancy and the better the outcome. PCOS, nobody asked for that. You didn't do anything for that. But the fact is that those are the cards that you were dealt. And the mindset is a very powerful tool in dealing with any type of setback, any type of challenge, okay? But having challenges and setbacks doesn't define you. How you overcome them defines you, okay? And there are always options. I think getting an empathic physician and getting one that's going to take ownership in your problem, but in a cooperative way, and tailoring the problem that fits you and how we move forward, that's a terrific formula.
It sure is. So I have one last question for you, and it's an important one because, again, you have made such a profound impact on this community. Why is it so important that we advocate and that we speak up and that we get involved?
For two reasons. One, from a patient standpoint, that they have to always be their own advocate. If they are not getting the care that they want from a physician, you got to go to another physician. You have to question your physician, find out why they're doing what they're doing. You know, the more you understand about the problem, the more compliant that you're going to be with the care that's being offered, right? If it doesn't make sense to you, it's hard to stick with something like that, right? Why am I doing this? Why do I have to get this blood test? What am I doing over here? Okay, that kind of interaction. Advocate, 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 and reach out to your representatives, because there's not enough being done for insurance coverage for infertility, insurance coverage for patients with PCOS. We're not getting the research for the NIH that's needed to try to do something to lessen the devastating impact of PCOS. I was so moved when I first went to DC with Ashley, and to see the energy, to feel the excitement and the love of the people that were there to advocate for measures to improve insurance coverage and research. I was sold. That was all I had to do. I will always advocate for PCOS. My practice provides a free IVF cycle in perpetuity every single year to the Polycystic Ovary Challenge, PCOS Challenge, a grant, anything and everything we could do for these patients and all infertility patients, of course. I'm in.
Thank you so much for your continued commitment, and I will see you again for PCOS Advocacy Day, which is going to be March 3rd of 2023. So I encourage everyone to sign up. It's open to register right now. Dr. Trolice, if you could please tell everyone where they can find you. I will follow up with providing the information in posts along with this, but just quickly, how do they find you and learn more from you?
Well, I'm in Orlando, Florida, and our website is vivfcenter.com. If you want to follow me online, it's at Dr. Mark Trolice. That's Dr. Mark Trolice. We have our website. We have tremendous numbers of YouTube videos at fertility care at youtube.com/fertility care, Facebook, Instagram. You know, we're obviously all social media. The important thing is that we are putting out content that patients can find as reliable information that is substantiated. Please be careful when you're online, because just because it's written doesn't mean it's supported with medical science, okay? So really, buyer beware, browser beware, surfer beware, okay? Go to the websites that are credible, like ASRM.org for the American Society of Reproductive Medicine, like reproductivefacts.org, PCOSchallenge.org. The American College of OBGYN is ACOG, ACOG.org. WebMD has good articles. I'm on Medscape. I write monthly, and I'm interviewed tomorrow on another article, research study that's coming out. So the internet is the most exciting place for the best libraries in the world, but it's also a lot of bad stuff out there that's not supported. So any questions, send us a note online. We answer everybody, and we wish you all luck. And I also want to leave with this, Ashley. The holiday season is one of the most difficult times, second to probably Mother's Day, when someone's trying to conceive. And I want to share with you that we get that. We know that when you're trying to conceive, the world is pregnant, and this is a time about children. But this is also your time. And if there are situations that make you uncomfortable, then avoid them. And people who love you will be able to understand that. And if they don't, then you have to question that relationship, okay? I also want to share with you, please remember, you are not defined by your ability to procreate, to have a child. That doesn't define you. People that brag about their fertility is like bragging that you're left-handed. You didn't do anything about that, okay? That was God's gift. But your talent is God's gift to you, and what you do with that talent is your gift to God. What you'll be defined by is your character, your contributions to this world of making it better and helping others. We spend a little bit too much time on things that we don't have. Well, no matter what we have, there is always opportunity to be grateful. Look for that gratitude and joy. You can find it. And when you do, it may help you get through these difficult times during the holidays and moving forward. So my prayers are with you all. God bless you, and take care.
Dr. Trolice, thank you so much for your words of wisdom, kindness, compassion, expertise. I could go on and on. Truly grateful that you are part of this campaign, part of this community, and looking forward to learning more from you as always. Everyone, thank you for joining us this afternoon for another Heart for PCOS interview, and keep watching throughout the month. And don't forget to turn from teal to red to support the largest at-risk group of women for cardiovascular disease, women with PCOS. Have a great day.